Hello and welcome to the Natus Neurotraining Academy webinar series. You may have noticed, but if not, I would like to share with you that our Neurotraining Academy has a new look and feel to it. Our NTA platform has become more engaging as we continue to provide you, our members, with direct access to the latest educational content in neurodiagnostics, neurocritical care, and neurosurgery, all in one comprehensive location. So check us out at neuro-training.academy. Again, that's neuro-training.academy. Today's webinar is entitled Ulnar Neuropathy. It's not just an elbow thing. This webinar will focus on the discussion of ulnar neuropathy and the tarsal tunnel syndrome, including an informative presentation on the anatomy of the hand and foot, history of entrapment, clinical signs and features, nerve conduction study findings, and differential diagnosis and case studies. I'm Dr. George Graziak, Global Medical Education Manager, Neuropathways, and I'll be your host for today. So before we begin, I would like to share some meeting details. All of your lines have been muted to manage background noise during this presentation. We will allow some time for questions at the end of the presentation, so please type your questions into the question box on your screen. This meeting is being recorded and will be available for viewing at a later date on our Neurotraining Academy website. Our speaker today is James Lewis. Jim is a distinguished board-certified clinician and educator specializing in nerve conduction studies and EMG. With decades of experience, he continues to promote high standards of clinical education, both nationally and internationally. During his career, he has been the recipient of numerous awards and accolades and past president of the American Association of Electrodiagnostic Technologists, AAET. Currently, Jim is a clinical application specialist at Natus Medical. So without further delay, it is my pleasure to introduce today James Lewis. James, please.
Hi. So I wondered where that little extra box popped up. There it is. So welcome. I'm Jim, just Jim. And so this presentation is in two parts. First, we're going to start with the ulnar, and then the tibial, the tarsal tunnel, comes a little bit later. So not both at once. It's a lot of information. So I always hate those pictures of myself up there. I try to get the camera high enough that you don't see my double chin, but low enough you don't see my bald head. Oh, that's tough. So here we go. So first, I think we've got a poll question for everybody right off here.
Yes, well, so usually in the beginning, Jim and I would like to get an idea of what our audience or who our audience is. So we'll launch this first question here just to get a brief indication of the level of our audience. So what is your level of patient care? Are you a physician in practice, technologist, director, manager, educator, or other? So if you can just cast your vote, we'll kind of get an idea of who do we have today. Wow, it's going pretty quickly here. Almost the entire voting audience here we have. Okay, so I will close the poll and then we can see the results. Okay, I will share the results with you. And it looks like, Jim, we have 56% physicians and technologists. So very impressive. Directors, managers, 3, others 7%. Great. Thank you very much for that response. I will hide the poll, and we can continue, Jim. Thank you.
Okay, great. So these are some of the things we're going to talk about in this first part. Certainly a little bit about anatomy, a little bit about the clinical features of what a ulnar neuropathy is all about. Talk about things that we have to separate, the differential diagnosis. We want to make sure that we're not making a mistake. And then we're going to talk about the nerve conduction findings, and then we'll look at some case studies. But first, and many of you are probably familiar with this, but I think it makes ulnar neuropathies extremely interesting to study, and that's what's called fascicular arrangement. So, you know, the fascicles are bundles of axons that are kind of, you know, destined to the final destination. They're going to the final destination, bundled together with those like axons. And I think kind of how they're arranged can really trip us up when we're doing studies. And that's part of what makes, when patients explain their symptoms, make it a little bit confusing sometimes, because it doesn't sound quite right, or it sounds different than we would expect. So, and we'll talk a lot about that. We'll talk about that several times, but it's what I call fascicular arrangement. So, so a little bit about anatomy. So here from the nerve roots, the ulnar nerve comes out of C8T1. It comes through the inferior trunk and right through the medial cord. So kind of in a way, the ulnar nerve is an extension of the medial cord. And then now, when I think of the brachial plexus, both the median and the ulnar nerve, the sensories and the motor go through different portions of the brachial plexus. So, you know, like the median nerve is, the motors are all through C8T1, and, you know, the sensories are all higher up. And the ulnar nerve is not that way. It is truly mixed all the way through. So it's just something we kind of have to think about as we're putting together our pieces to the puzzle. So, yep, ulnar nerve is essentially a branch, and then medial cutaneous nerve, or the medial branch in the medial cutaneous nerve of the forearm, come off directly from the medial cord. So they can be used in the differential diagnosis. Is it really an ulnar nerve lesion, or is it a brachial plexus lesion? And that's where it can be helpful to us. So a couple things about anatomy: there are no muscle innervations from the ulnar nerve above the elbow, and then the nerve continues through the epicondylar groove, which is, you know, it's that what do you call it, funny bone. It's where we can kind of tap our elbow and make it shoot some numbness down there. We've probably all done that before. It's really nothing funny about it. It really kind of feels bad, but it is actually the most common place for compression. But as the nerve continues just a few centimeters on distal to the epicondylar groove, the nerve dives deep down below the flexor carpi ulnaris muscle. And the flexor carpi ulnaris muscle has kind of two heads, and kind of holding those two heads together is this very thick fibrous tissue. And that's the second most common, and often we call that cubital tunnel. Both are kind of, the cubital tunnel name is maybe not the best, but we still do call it that. So then it continues down the forearm. It doesn't give off any additional muscle branches until very near the wrist. And then there's a branch that comes off just proximal to the wrist, the ulnar dorsal branch, or what we used to call the duct, the dorsal ulnar cutaneous nerve, comes around and supplies the dorsal medial half of the hand. And then, of course, a little bit on past that is the dorsal cutaneous branch, which is their sensation over the hypothenar area. And then, of course, at the level of the wrist, the ulnar goes in through Guyon's canal, and that's basically formed by some of those carpal bones in our wrist. And the nerve branches kind of as it goes into the canal, and then as it leaves the canal. And because of that, their ulnar neuropathies at the wrist can be a little bit confusing, because some of the symptoms kind of depend on where it's entrapped inside that tunnel. And again, we'll talk more about that. So it goes through the cubital tunnel, and then it supplies all the muscles of the hand, with the exception of just the first and second lumbrical, and then the thenar muscles. Other than that, it's all ulnar in the hand. So there's a quick picture, and this is really, we're going to see this picture a couple times when we're describing the, where the nerve's entrapped in an ulnar nerve lesion at the elbow, and later in the ulnar nerve lesion at the wrist. Kind of, we'll talk a little bit about that, but this is just kind of an overview of what it looks like. And so let's just jump right in. So what are some of the things we see in an ulnar neuropathy at the elbow? And again, because kind of that fascicular arrangement, I think sometimes there's a lot of variation when the patients are explaining their symptoms. It doesn't always quite make sense, and I think it's partly, where's the entrapment at the elbow, and is it getting some of those deep fascicles or just the superficial fascicles? And so sometimes it's a little bit confusing, but certainly numbness in the medial portion of the hand, so digit 5, and the medial portion of digit 4, and again, dorsal side as well, depending on where the lesion is. And then as it gets more advanced, if you keep a compression for a long period of time, you're going to start losing muscle, right? And you'll start getting weakness, pain, clumsiness. You start dropping your coffee cup, things like that, because the muscles actually get weak. Pain, common, but again, not universal. Maybe it's just the sensory, involvement. So, and some of the things you can do, the Tinel sign, you know, if you tap on it, I don't know if you guys ever do Saturday night at the party, but sit there and tap on your nerve where it's very superficial. It makes a lot of friends, but you can actually make the numbness kind of shoot down into your fingers, and that's called the Tinel sign. So, so again, a couple different sites where the ulnar nerve can be compressed or entrapped at the elbow, and certainly right there at the retroepicondylar groove is the most common. Okay, the nerve is very, very superficial there, and that's why we can tap on it and create those symptoms, because it's very, very superficial there. You know, are we leaning our arm too much? Are we compressing it when we do that? Sometimes it slips in and out of position there as we move our elbow. And those right there at the elbow, right there at the epicondylar groove, is probably 2/3 of all ulnar neuropathies that we see. And then of course at the cubital tunnel, as the nerve dives down deep below the muscle, there is the second most common. It's more like about 1/4, and sometimes those do require surgeries, not always, but it's a little bit different place. And that's why sometimes when we talk about how best to diagnose it, it's the level with the needle, certainly, but it's also things like inching studies. Can we localize exactly where that compression is? And then we'll talk about some of the differential diagnosis. So these are things we need to separate from the ulnar nerve at the elbow. And certainly one of them is the ulnar neuropathy at the wrist. And we separate that primarily by testing the dorsal ulnar, or the ulnar dorsal branch, sorry, the new words, ulnar dorsal branch, or what we used to call the duct, the dorsal ulnar cutaneous nerve. And because if that sensation is preserved, the lesion cannot or should not be at the elbow. Should not be at the elbow. Again, we see it sometimes. It's a little bit confusing, but if the ulnar dorsal branch is normal, consider a lesion higher up, more proximal. Don't consider the lesion at the wrist. And that's so dorsal ulnar ulnar neuropathy at the wrist is part of the differential diagnosis. Certainly lower trunk medial cord plexopathies are part of the differential diagnosis. And again, kind of when we think about that, you know, when we consider plexus lesions, maybe we'll do the medial antebrachial cutaneous nerve. Again, there's new names for it, and I forget the medial cutaneous nerve of the forearm, and see if it's affected. Because if it is affected, we're thinking more proximal, more like a brachial plexus, where if it's not involved, then we can hang our hat on the ulnar neuropathy. And also, again, think about the way the median nerve through the brachial plexus. If the median motor is affected, you might also think plexus. If the ulnar motor and the median motor are both affected, you might think plexus. Where if the median is preserved, you might not. You might think just ulnar. So some of those kind of things to think about to separate the plexopathy. And then probably the biggest one we have in our differential diagnosis is the radiculopathy, CAT1 radiculopathy. And again, you know, where's the pain? Where's the problem? Is it primarily weakness, no numbness, or is there some numbness as well? That helps us separate the two, because again, the radiculopathies are preganglionic, so our sensory nerve conductions for sure would be normal. And then we'll talk about we'll talk a little bit about the clinical features of the wrist now. And again, there's a lot of overlap. The ulnar nerve is the ulnar nerve, but depending on where it's entrapped, we can have some deep palmar motor lesions that spare the sensory. So the sensory is intact when it's at the wrist, so the sensory to the fourth and fifth digits, as well as the sensory branch above the hypothenar, where those are spared. But you might have some muscle weakness in the interosseous muscles of the hand. And so these are just some of the places. So the proximal deep motor branch affects all the ulnar innervated hands, including the hypothenar, but the sensory is spared. Where proximal, the ulnar innervated in the hand, all of them are affected, and the sensory branch. And then, of course, there's the pure sensory branch where it spares the motor. And again, that depends on where the nerve, as it goes through that canal, where it's entrapped, where it's compressed. 75% are actually combinations. Again, I think this is what makes ulnar neuropathies very challenging. I think we have to kind of put the pieces together carefully. Weakness, wasting, you got to be careful that, also, if you do have a little bit of wasting over in the thenar, on the median side, don't forget that the flexor pollicus brevis is dual innervated. There is some ulnar innervation over there. Of course, that would be part of the motor, the deep motor branch coming over. And then, of course, looking at proximal lesions, dorsal sensory innervation is spared. Again, if the lesion's at the wrist, because it comes off proximal to the wrist. And there's the picture. So I don't know if my mouse shows up on the screen. I don't know if you can see that, but down here toward the bottom, you'll see that I have that red bar across. And in that case, I'm getting both the sensory branch straight down, and I'm getting the ulnar branch that gets both the hypothenar and the deep ulnar branch that comes across the palm of the hand. And again, kind of showing where those lesions can be. In the differential diagnosis, we certainly have to separate an ulnar neuropathy at the wrist from an ulnar neuropathy at the elbow, and likewise the other way around, which we've kind of already talked about. But one of the things we have to be careful about are motor neuron disease. If there's painless atrophy, weakness, wasting of the muscles, that's got to be in that differential diagnosis as well. Okay, so, and again, the pieces to the puzzle that we're putting together to show the picture. More proximal lesions. That thing was in my way. In more proximal lesions where the sensory is affected, ulnar neuropathy at the wrist can easily be confused with ulnar neuropathy at the elbow. Okay, but again, dorsal ulnar sensory in the hand is preserved. Think wrist, don't think elbow. But as stated before, sometimes because of the way those fascicles are arranged inside the nerve, sometimes it doesn't appear quite that way. Again, that's why we think about this as a global thing. And also in the differential diagnosis of ulnar neuropathy at the wrist is also C8T1, just like it is in the elbow lesions. Okay, good. So let's get to the meat and potatoes. This is what we find on the study. This is kind of how we put it together. So again, because of the way the fascicles are kind of arranged, and by the way, if you have Preston Shapiro's book, look at ulnar neuropathy at the elbow. It's one of the sections at the back. I think it's page 307 in the newest edition. There's a great picture of this that can describe it far better than I ever can with the words. So sometimes we do see the dorsal ulnar branch may escape injury with lesions at the elbow. And fibers to the FDI may seem more susceptible to injury than those to the ADM. So again, it doesn't always fit perfectly. And again, that picture in Preston Shapiro will explain that better than I can here. And it's a great picture. Same thing with the deep motor branch. Different fascicles may show more abnormalities or a conduction block over to the FDI, while those to the ADM may appear just to be some low amplitude. And that's why it's so important to be careful. So what do? So first thing we do, of course, is the median and ulnar sensories, sort of your antidromic sensories. Again, these 12 to 14 and 11 to 13 are just recommended standards. We do a median motor. We got to do a median motor so that we can prove that it's normal, because it would be unaffected in the ulnar lesions, but might be affected if it's a lesion higher up, like in the plexus. So these are things that we just normally do, okay? And these are all we kind of compare to our lab standards. And these are pictures. So these are the antidromic median upper left, the motor study upper right, and then of course again another antidromic median down there at the bottom. So there's another question.
Sure. Okay, so this question was a really good question, actually. So in this question, we would like to kind of get an idea of your familiarity with nerve conduction technologies as a user, or just starting out and interested in clinical or technical training and information. So we'll launch this question here. So are you currently using, by chance, Natus nerve conduction EMG technology system? Yes, no, other manufacturer? No, but would like more information if you're just starting out, or setting up a lab, or setting up a private practice. So let's see what our response will be here. We're getting a quick response here. All right. So, okay, let's close this poll. I'll share the results with you. So what we have is 69% are using Natus equipment. Excellent. And then other manufacturers 24, and 8% would like some more information because they're starting out or trying to enhance their practice. Excellent. Thank you very much for that response, and we will continue. Very good. Continue, Jim. Thank you.
Okay, so so we talked about some of those studies we do. Now we talked about the median and the ulnar sensory. Now let's talk about the median, the ulnar motor to the hypothenar. And again, that's a standard study. And one of the things here, when we talk about, measuring the length of the nerve, we have to put the arm at about a 90-degree angle so that we stretch that nerve across the elbow. If we leave our arm out straight, it's kind of bunched up together, and the measurement on the skin won't equal the measurement when the nerve is taut. So 90 degrees, make sure that we don't stimulate, as we look across the elbow. And again, we want to kind of do, and with any entrapment, we want to, if we can, we want to look below and above the entrapment so we can see the difference. So here we would certainly do the wrist stimulation and then try to get below and above the elbow. And just a couple things, if we get too distal below the elbow, the nerve buries a little bit deeper, and then we find ourselves turning up the stimulus quite a bit more. And it always kind of makes you wonder, did I overstimulate? Did I get some stimulus jumping? So it's nice not to get too far away. I think it makes it a little bit more challenging. And then sometimes we move on proximal. Certainly if the conduction velocity across the elbow slows, but the morphology stays about the same, you might want to move up to the axilla to show that it speeds back up. And this is especially true if you've got a low amplitude all the way down. If you've got that Wallerian degeneration where the axons are kind of dying back all the way down to the distal site. So some of the things we look for, there's the picture. So this is kind of how we do the below and above. Again, we want to look at the entrapment by going above and below the entrapment. And that's all entrapments. So what we look for is, does that slow a lot? Does that slow more than 10 to 15 meters per second as you go across the elbow? Does the amplitude drop? Does it drop 20% or more? And if it does, be real careful that we're not looking at a Martin Gruber's. The Martin Gruber should show a lower amplitude in the below elbow segment as well. But we have to be careful to separate that in our mind. But also look for, does the morphology stay the same? Is there a conduction block? Is there temporal dispersion? So is it just slowing with a little bit of amplitude drop, but the morphology looks the same? A little less severe. And those are some of the things that we want to look at. And then, of course, we can always move up to the axilla, see if it speeds back up again. And again, always looking at the morphology of the waveform. You want it to look the same. And one of the other things, and I think I didn't know this for many years, if you get just a little bit of slowing, and again, the morphology looks about the same, don't forget that if you have a little bit, if it's a little bit cooler, if your temperature is a little lower at the elbow than it is at the wrist, you might see what appears to be slowing that may be just related to the temperature. It's always worth taking a quick temperature measurement at the elbow just to kind of see that. Sensory, especially sensory inching, but sensory potentials across the elbow. There's some pitfalls, but they can be very useful if they're sensory symptoms. I say they're a little bit difficult only because, you know, when we measure conduction velocity, we're measuring it from the onset point. And I think, as you know, those sensory onsets aren't always perfect. So we have to be a little bit careful. Again, being compulsive is the key. Some of the other things we do, certainly motor studies to the first dorsal interosseous. It localizes lesions in the deep ulnar branch in the Guyon's canal. But it can also be useful, and again, I think I've said it, it's also very, very useful in ulnar nerve lesions across the elbow. Because again, the way the fascicles are arranged inside the nerve, the fascicles going to the FDI are a little closer to the surface. And again, that picture in Preston Shapiro. Boy, you see that from across the room, you know exactly what we're talking about. Inching is a very, very great tool. Looking at the small, short, or the short segments across the elbow, you can really help localize, is it right there in the epicondylar groove, or is it more distal to that? Again, be very careful, because you're measuring in very short distances, so you have to be careful about it. Don't put more pressure on the cathode at this site and then more pressure on the anode at the next site. Make sure you're doing everything very, very, very much the same with each segment. But it's a valuable tool. And here's the FDI. So here we're measuring the ulnar nerve kind of at the same place we did when we did, or the stimulation sites are the same place as they were when we did the ADM over on the medial side. But here we just move our electrodes over and we measure. That way we're looking at that deep ulnar branch as well. And that's a good picture of that. And here's the inching. And again, this kind of shows how it can be a little bit, a few pitfalls. You know, just have to be very, very careful. You look here at even my little lines there with the pin. They're different widths, you know, so we have to be very, very careful about how we mark this so that we're consistent. Some of the other things to do is comparing the below to above elbow segment to the above elbow to axilla segment. Again, this is really nice if you got some slowing across the elbow, but you also got some low amplitude distally, because this is going to, you know, is it going to speed back up, or do we really have a lot of axon loss? Dorsal ulnar branch as well, because again, sometimes it'll fool us, but it is important to do that to separate or to show that the lesion is at the wrist. Medial cutaneous nerve of the forearm, medial antebrachial cutaneous nerve, certainly separates brachial plexus lesions, because they will be, the medial cutaneous nerve of the forearm will be spared in ulnar nerve lesions, but might show abnormalities in lower trunk medial cord lesions. F waves can be used, but they may not be much value. And again, some of these are a little bit of my opinion kind of superimposed in here. But needle EMG will definitely tell you more about the prognostic stuff. How severe is it? You know, is there a little bit of denervation, or is there some loss of motor units as well? All right, we're doing great. Okay, so here I'm going to show just a couple case studies. Again, I'm going to put any abnormalities. Again, my lab is going to show they're bold. Okay, so I'm going to try to show them all. Okay, some of the ones that are just not applicable I didn't actually show, but so here we go. So here I did the left median nerve, left ulnar nerve, and the only thing we see is a little bit low amplitude in the ulnar, but do you see the real severe drop as we cross the elbow? And look at the conduction velocity. So I'm kind of focused in the bold numbers here. So here we're showing both an ulnar neuropathy at the elbow, but also a little bit of Wallerian degeneration. We're losing axons distally as well. So there's some pictures to kind of show that. And this, for you veterans anyway, is done on a little bit older Viking. So this would be like the Viking Select. Now, of course, I go over to the right side. There's a little bit of slowing too across the elbow, or some slowing across the elbow. Again, the morphology looks good, but I don't have that low amplitude distally, so I don't have as much axonal loss. I don't have as much Wallerian degeneration. Does that make sense? Good. And then in the sensory studies here, I show the low amplitude to the fifth digit, and I show a little bit on both sides. So there's low amplitude on the opposite side as well. So this, of course, on the right side is the side that did not show the Wallerian degeneration. The lower amplitude is on the side that also had the mildly low amplitude distally. And again, a Sural's here in our lab, again, in a teaching hospital. If we had abnormalities on both sides, we'd go ahead and just check a quick Sural to get a gauge if there's some underlying neuropathy as well. And that's why the Sural's on there, but not real important here. But bilateral ulnar neuropathy is localized to the region of the epicondylar groove. And again, the more axonal loss on the right or on the left as compared to the right. So that's where we talk a little bit again about Wallerian degeneration. And another question.
Okay, so here we're going to launch this question. Let's test your knowledge and if you're paying attention. So what is Wallerian degeneration? Demyelinating axon disruption or axonal disruption distal to lesion, demyelinating proximal, or just another fancy word for entrapment. So we'll see what our audience thinks of this clinical question. Okay, we're doing pretty good. A little more. We're trying to get at least 70%. Okay, so we will close this poll and let's see what are we. Demyelinating axonal disruption distal to a lesion, 43%, and a close second of axonal disruption distal to a lesion. Here you go, Jim.
So when I think when I think of Wallerian degeneration, I think of the dying back of the axons. So from the lesion moving distally. So the second one is the right answer. So whenever you're looking at an entrapment, if you have a lower amplitude distal, you're thinking, I'm losing some axons. And again, what that means is it's probably a little bit more severe, or it's been there a little bit longer. And so the myelin's affected, yes, we see that just in the slowing. But with the axons also being affected, it's a little bit more more severe, or it's been there a little bit longer. And again, I don't consider myself that smart, but I read a lot of books. And the very best picture, so when we think of nerve injuries, so nerve compression, nerve entrapments, nerve injuries. They're basically the neuropraxia, which is myelin only, axontomesis, which is demyelinating and axonal. So that would be what we're talking about here. The axons are actually dying back, so you've got some axonal injury as well. And then, of course, neurotomesis, which is the most severe. That's where the supporting structures are also injured. That's like when a nerve is severed. So, but again, the very best place, Shin Oh, he has a book that's it's really quite old. I don't think he's updated his book for a while, but in there he actually draws pictures of what these look like. And again, for guys like me, in words, it kind of makes sense, but then when you see it in pictures, it makes a lot of sense. So that's the difference between a neuropraxia injury and a axontomesis injury, because the axons are also affected. Okay, and I think we're going to show that here because, well, we showed it the first one too, but here we have some numbness in the 4th and 5th digit for a few months. And here, the little circle didn't quite make it where it was, but it's normal. You know, there's 5 meters per second slowing across the elbow, not profoundly significant, so we call that normal. But then if I move my electrodes over to the FDI, here we can see the slowing. It's more obvious. Here we're talking 12 meters per second. And again, this is all about the fascicles, the way the fascicles, the fascicles that are together, the fascicles make up the nerve. So you got the axons together in the fascicles and the fascicles together in the nerve. And the way these fascicles are arranged in the nerve, the FDI is closer to the surface of the skin, so a little bit more vulnerable to, where the nerve is very superficial at the elbow. And that's what we're showing here. So here, normal, and the nerve conduction recording to the FDI reveals slowing across the elbow. But the ulnar nerve to the ADM was normal. And that's kind of the key. All right, number 3. Again, they'll be bold if they're abnormal. Injury to the hand, so you already know where we're going, don't you? So let's take a look at an ulnar neuropathy at the wrist. So here, the ADM is the ulnar motor study to the ADM is normal, but we can't record an ulnar motor study to the FDI at all. So where do you think? Probably the deep ulnar branch. And again, we can't answer that until we look at the sensories, but if the sensories, the dorsal ulnar cutaneous is spared, or is spared, but the ulnar sensory is spared. So this is at the very distal end of Guyon's canal, where we're getting just the deep motor branch that comes across. So this will be most of the dorsal interossei. Will be all the dorsal interossei, including the first dorsal interosseous, would be affected, but the hypothenar would be spared. So deep motor branch, ulnar neuropathy at the distal portion of the Guyon's canal. Normal sensory to the 5th digit. Dorsal ulnar cutaneous is normal. Okay. So in conclusion, we're doing great here. So ulnar compression at the elbow is the second most common mononeuropathy, but it can be challenging. And again, I think what that means to most of us is we have to be a little bit obsessive compulsive. We have to put those pieces together when they don't make perfect sense. And there's a bibliography, and I believe this whole presentation is available for you to download. And so you can take a closer look to those. And there's Chenot from 1993, and that is the best book for showing nerve injuries. Okay, so let's flip schedule a little bit here, and let's talk about the foot a little bit. Another entrapment neuropathy. Tarsal tunnel is a little bit controversial. So we're going to look at it just a little bit. We'll look at a case study. We'll look at what we do for nerve conductions. But I think part of why it's, and I shouldn't use the word controversial, I think a little bit hard to separate from just local trauma to the foot. I mean, our feet take a beating, or running on the treadmill in the morning and walking across hot asphalt in Tucson, Arizona, our feet take a beating. So I think controversial is not the right word, just challenging is the right word. So talk a little bit about the bones of the foot. Again, download the presentation so you can look at all those. The key is kind of the nerve, the tibial nerve splits. A little bit about the anatomy. The key is the tibial nerve kind of splits right behind the medial malleolus. And there's the medial plantar that, of course, supplies the abductor hallucis, an important nerve when we do our nerve conduction. That's where we do our tibial nerve conduction studies or motor nerve conduction studies. But then the lateral branch goes over to the other side of the foot and supplies, boy, a lot of it in there, and supplies your ADQP and flexor digitorum, yeah, those words. So there's a lot of stuff here. Sorry I didn't pay as much attention there, but the flexor digitorum brevis over on the lateral plantar side. And we're going to talk a little bit about that. I want to make sure I leave at least 10 minutes for questions. So, and a lot of this kind of stuff is, I mean, I can read it, but you can read it too. So tarsal tunnel, the most common entrapment in the foot. Fibrous canal formed by the ligament down there right behind the medial malleolus. It gets compressed. Again, the key is separating this compression from local trauma, and it can be a real challenge. Rare, very rare. Mostly in adults. Women get it more than men. And here's some of the reasons, same ones we see for a lot of the compression. Gradual progressive burning on the bottom of the foot, on the plantar side of the foot, pain, paresthesias, numbness, again, difference between the burning and the numbness here, both paresthesias, and symptoms worse on standing. And how do we diagnose it? So, listen to the patient. Certainly MRIs, ultrasounds, x-rays, we can look at all those things. But again, we're going to focus on that very last one, and that is the nerve conduction EMG. And so we want to focus on the two branches, the medial and lateral plantar of the tibial nerve. But we have to keep in mind that, make sure that we're not missing a sciatic neuropathy or a lumbosacral radiculopathy. And again, 50% of the time, our nerve conductions are normal. And again, I think that's part of those pitfalls. What's happening here? Is it just, running on the treadmill an hour a day and now the bottom of my feet are numb because I'm, putting that pressure on them as I run? Okay, so again, being cautious. Differential diagnosis, so and strategy. So medial plantar nerves, side-to-side comparison is very important. So if I have that painful numbness on the right side, be sure to do the left side as well. Let's make sure we have a good comparison, and both sides. So let's do the abductor hallucis, but let's also do the flexor digitorum minimi brevis or the ADQP, either one, and that's the motor part. And then, of course, the sensory part, sometimes we do the orthodromic, where we stimulate in the sole of the foot and then measure up there to behind the medial malleolus. And that's really a mixed nerve. But sciatic nerve lesions, of course, the peroneal may be affected as well. But we'll also look at, so we'll look at that, and we'll look at that with F waves, again, to separate a sciatic nerve lesion. And then, of course, the sural would help localize as well, because it should be normal. The sural nerve should be normal. But again, if you saw this in a patient with an underlying neuropathy, then the sural would be abnormal, and again, adds some confusion, and it means we have really good at what we do. There's a picture of the foot. So over here is the abductor hallucis, and over here is the abductor digiti quintae pedis. So treatment, conservative, orthotics, surgery if it's a last resort. Generally conservative at the beginning. Surgery, release of the tibial nerve and its branches, and again, that's, I don't know, it's again a little bit controversial. Sometimes it doesn't help. Even when you're sure that you're sure, it still doesn't help. The feet are tough. The feet are tough. And that's that last segment there where it talks about outcomes. 44% to 91%. So it's difficult. So then the nerve conduction study is good. We're doing good. So we do the fibular nerve, but it should be normal. Okay. Now we focus just on the motor portions, but remember, the fibular nerve is a mixed nerve as well. I mean, the deep fibular nerve is a mixed nerve as well. Okay, so yep, that's where we put our electrodes. That's where we record. Sorry about that. Again, I won't spend any time on this screen. And there it is. So here we're stimulating, and the active electrode is over the extensor digitorum brevis. Again, this one is spared. So this one would be normal. And then, of course, we do below and above the fibular head so that we're not missing peroneal nerve lesion, so we can focus on the tibial where the tarsal tunnel is. And then the tibial nerve, the medial plantar is, so the tibial nerve is the largest division of the sciatic nerve, and it innervates these muscles all the way down to the foot, but common muscles that we're used to. And there's where we stimulate for the medial plantar. And here's a good picture of it. So the abductor hallucis is down there. If you kind of feel for the navicular bone, it's a long, thin muscle. So it's not one that you're going to palpate as well. But if you kind of feel the navicular bone and just move down a centimeter, you'll be in a really good place. So here we're going to stimulate behind the medial malleolus and get the distal motor latency, the motor response. And of course it splits. There are actually 3 branches, but the tibial motor, the medial plantar, goes to the abductor hallucis, which is the medial, and then the flexor digitorum minimi brevis, or the ADQP, is the lateral branch. And when we look at the lateral branch, you see my active electrodes over here on the opposite side, on the small toe side. And again, I'm stimulating in the same place behind the medial malleolus. So, and then we do the sural nerve. We do the sural nerve again, so it should not be affected. And there's how we do the sural nerve, kind of on the side behind the lateral malleolus. And then we do the mixed nerve, where we're looking here, stimulating the medial and plantar mixed nerves in the sole of the foot and recording behind the medial malleolus. So these are a little bit different electrodes. These are the older. I'm stimulating with a bar here and using those Alpine, or now Natus, disposable electrodes. And here we are over the lateral plantar mix. And so I'm going to compare those. Those are both at a fixed distance and an equal distance, so I can kind of compare apples with apples. What is the latency? Amplitude's a little bit lower on the lateral side, but definitely compare the latencies. And I didn't talk as much about the motor there, but I also do the motor comparison, and I kind of look at the differences. So if the medial plantar should be faster, it should be quite a bit faster than the lateral plantar in the motor studies. So I allow between 1 millisecond and 3.5 milliseconds difference between the two. So if the lateral plantar is more than 3.5 milliseconds longer than the medial plantar, that would be significant of a lateral plantar injury. But if the medial plantar is less than 1 millisecond faster than the lateral plantar, that's significant of an injury in the medial plantar. So here we go. Foot pain, numbness, tingling, it's long. Yep, all that good stuff. There's a physical exam. I put it all in there for you. And of course, no response over the lateral plantar on the left side, but I did get a response on the right side. And again, no response over the medial either. And then yeah, the left side is non-responsive. So again, what's the diagnosis and why? Well, normal in all except for the localized abnormalities of the left lateral and medial plantar nerves, consistent with focal tibial neuropathy of the right tibial nerve, and that makes no sense to me. Did I read that carefully? Because up here I say localized to the left lateral medial plantar, and down here consistent with focal neuropathy of the right tibial nerve, such as in tarsal tunnel. That I should proofread faster, but I sped around a little bit there. Here we go. So here's another one. And again, we're going to focus on peroneal's okay, tibial, right peroneal. So down here, no response in the left medial or lateral plantar. There we go. There's some pictures. Sorry, it's 10 till, and I want to make sure I have time for questions. But again, download the presentation. I gave it to everybody. So, so those will be there. So I want to make sure that we have time. There we go. So George, do you want to?
Yes,
okay.
We have some questions here. Thank you, Jim. A great presentation. We have some time for a few questions, and let's start with this question from one of our audience members. What is stimulus jumping?
So we know that on motor nerve conduction, especially, the negative ions are coming out of the cathode, which is on the skin, right? And those negative ions go down and they activate the nerve, okay? And we're looking at it kind of in a picture of it being right below the cathode is where the nerve gets activated. And that's where the nerve depolarizes and sends the impulse on down the nerve. Well, if I overstimulate, I can actually see that latency jump. Maybe it'll jump a millisecond. And you can see that when we overstimulate. So the thing on motor, and this is one of the reasons that we get good at our job, is because we want to do a super maximal stimulation on motor nerve conductions, but we don't want to overstimulate either, because we overstimulate, we'll get that what I call stimulus jumping. So if we look at that nerve and we look at the nodes of Randiver, that's kind of where the activation begins in the nerve. And if I stimulate too much, instead of activating the node right under the cathode, I'm maybe activating the one before it. Okay, so the stimulus spreads and activates the next node. Does that make sense? Again, if I could draw it, I could show that to you really easy. But we see it a lot when we stimulate, we get our super maximal. Okay, so we've already done our distal, maybe we're up at the proximal, so we kind of already know. But as we're looking at it on the screen and we turn it up a little bit more, we actually see the latency shift to the left a little bit. And that's what I call stimulus jumping. And it's just because we've activated the next proximal or the next distal node closer to the electrodes. And again, it's something to be careful about. Is it 1.5 milliseconds? Well, that can make a difference.
All right.
Does that help?
Thank you. I'm sure it does. I'm sure you can always email us if you need more clarification.
Oh, absolutely. Anytime.
Thank you. So here's the second question. Have you ever compared the difference of latency between the median and ulnar for a diagnosis of cubital tunnel? Orthodromic stimulating at the forearm and recording at plus 10 centimeters above the elbow. I think I read that correctly.
I have not. So read that one more time. Maybe I need to get my head around it. Read it one more time.
Okay. Have you ever compared the difference of latency between the median and ulnaris for a diagnosis of cubital tunnel? And then it's clarified in parentheses, orthodromic stimulating at the forearm and recording at plus 10 centimeters above the elbow.
I haven't. I usually limit myself to just distal to the elbow, not clear down in the forearm. And again, maybe I'm concerned about the depth of the nerve there and the amount of intensity. It sounds like it would work okay, but I had never done it. And probably, again, because of the depth of the nerve. I don't want to turn up the stimulus so much to get the deeper nerves, but it you know, on the face of it, it seems like that would be okay.
Okay. Here we have a question. This person had a patient with a CV difference above and below the elbow was 12, but above the elbow, the CV was 48. Do you consider that as ulnar neuropathy across the elbow?
It, again, making sure that everything else is accounted for. So what you're saying is that it dropped from 60 to 48. So 60 in the forearm, 48 across the elbow. So a 12 meter per second drop, but the 48 still being within normal limits of the nerve in general. I still would consider that, assuming that I've eliminated any anomalies like Martin Gruber's, and making sure that I double check the temperature. See, that's one of those ones where sometimes we get that borderline one where it's worth checking the temperature at the elbow. You know, again, we've got that temperature probe down there on the wrist, and of course we warmed them up, you know, or we at my place would always warm up our patients in a warm bath, but sometimes they wouldn't get clear up to their elbows. So there might be a 2 or 3 degree difference, which of course, if you've got a 2 degree difference, that's 4 meters per second, give or take. And if you've got 4 meters per second slowing across the elbow, if you reduce that 12 down to 8, then it puts it in the normal range. So again, always being sure that we've thought of the other possible things. Okay, so if I've eliminated those, there's no anomaly, the temperature's good, I probably would call it ulnar neuropathy. Again, my doc would probably say things like very mild or something like that, using terms so that they don't, so the doctor doesn't start cutting on it right away. But challenges, and that's why I love the ulnars.
All right. Thank you again, Jim. And we have here is, what is triple stimulation?
So triple stimulation is where we want to do the collision study distally, and then the third stimulation is actually a cortical stimulation. So if I think about that, if I had a stimulation at the wrist, and then I put a interstimulus interval proximal, so it could be up in the axilla herbs or someplace like herbs, and I put an interstimulus interval, so those two potentials cancel each other out. And then the third stimulus is using like a magnetic stimulator over the contralateral motor cortex. I could measure that time, that central conduction time. Okay, so it's not something that's very common, and we don't actually see that in the United States at all. But that is something that I think in the Netherlands, they wrote some really great papers about it, and there's some really nice work. So there's some normal values for it, and in our software, those interstimulus intervals and things like that, they're all built in. So it's pretty easy, other than you got 3 stimulations, you know, it's electrical stim, magnetic stim, like boom, boom, boom. And I've had it done on me, not a lot of fun.
Okay.
So central conduction time is the key.
All right. Thank you. We have, I think we have time for one more. This one is, what do you do to check for Martin Gruber at the elbow?
Great question. So, oh boy, and this could be an hour by itself. So there's really 3 kinds of Martin Gruber. There's 3 different places where the median nerve travels to the ulnar nerve in the forearm. So the motor fibers kind of come across. So anytime I'm doing the ulnar nerve, when I think of ulnar nerve, if I get an amplitude, let's say 10 at the wrist, and it drops to 5 at the elbow, and I check to make sure I'm super maximal. I check to make sure I didn't, co-stimulate at the wrist. So I do the usual thing, and I can't get it any more than that. I start thinking right away of Martin Gruber, because those median fibers have already moved across to the ulnar nerve. So there's more fibers at the wrist than there are at the elbow. Now, you can also check for it in the median nerve. And again, if they have carpal tunnel in the median nerve, I think Martin Gruber jumps out and slaps us in the face, because it's real obvious. But if they don't have a pretty significant carpal tunnel, I think Martin Gruber, we can miss it. But type 2 Martin Gruber, which is the most common, involves those fascicles going over to the FDI. So again, I think we can miss Martin Gruber if we don't do FDI studies to the ulnar nerve. So if I get a little bit of drop from the wrist to the below elbow site, maybe I don't worry about it. But if I went ahead and got over to the FDI, I might see a more significant amplitude drop. So just think of fibers from the median nerve moving over to the ulnar nerve. And that's why the ulnar nerve distally is of higher amplitude. It's got more fibers. Does that make sense? But again, I could present an hour just on that.
Okay, thank you, Jim, for that. Well, this will conclude our webinar for today. I would like to thank Jim Lewis for his excellent and informative presentation, and to you, our audience, for your participation. Please contact us via email should you have any questions regarding today's webinar. Our email address is neuro-training.academy@natus.com. For access to future events and all other educational programs at Natus, I invite you to join our Neurotraining Academy, in which the registration is free. So just visit our website or sign up at neuro-training.academy. Again, that's neuro-training.academy. Don't forget to review the handouts for this webinar, which includes some very informative technological information along with a PDF of today's lecture. So on behalf of Natus and our Neurotraining Academy, thank you for joining us today, and we look forward to seeing you next time. Goodbye. Thank you.